Next, we have Dr. Rosanne Freak-Poli from Monash University. And for those of you who might have been at the panel session yesterday afternoon, you would know you're in for yet another treat having Rosanne up here. Rosanne is a life course epidemiologist, and she's a senior research fellow at the School of Public Health and Preventative Medicine, and a newly appointed role at the School of Clinical Sciences at Monash Health. Welcome, Rosanne.
Thank you. I'm Dr. Rosanne Freak-Poli. Thank you for the introduction. I'm a life course epidemiologist, which means that I'm interested in things across the life course that impact our health. I'm interested in how things change over our lifetimes. I'm sure we all can think of ourselves 20 years ago and reflect that we've changed in that time. And also with a focus on social determinants of health. So that's things that are not medical that affect our health. I've previously been funded by NHMRC to assess happiness and health. The takeaway there is it's optimism, not general happiness, that affects your health. And also by the Heart Foundation to assess social isolation and cardiovascular disease, which is where I entered this space. My contribution has been to understanding the population impact of health. I've demonstrated that social health is associated with the greater severity of chronic disease risk factors, so thinking about the pathways into health, lifestyle and biomedical risk factors, lowest quality of life, increased risk of cardiovascular disease and dementia, as well as worse health, mental health during CVD recovery or cardiovascular disease recovery. And one of the points that I found from this research, so once you have a cardiovascular disease event, that we are not doing a great job at thinking about, it came up yesterday in the health equity panel, at helping people from different CULD, which is cultural and linguistic diverse communities in hospital. One of the things I found was that if you're from Aboriginal or Torres Strait Islander communities, they want to leave hospital sooner because they want to get back to community, and that's not really integrated in our healthcare system. So one of the things I've been doing is assessing social isolation, social support and loneliness separately. I spoke a little bit about that on Monday. If you missed it, it has been recorded. And one of my questions was to the audience is whether we need sort of public health messages around social prescribing. And we've just seen a great talk by Professor Thomas Atzelbert demonstrating how powerful it is to have this public health message that we need for our health 30% green spaces around us. So this is the sort of research that I've been interested in progressing. Today, I'm going to be talking about more my perspective on evaluating social prescribing. So I love numbers as an epidemiologist. I love thinking about what goes into the numbers, how we interpret these numbers. And in the context of evidence around social prescribing, I want to highlight that as my PhD, I evaluated a lifestyle intervention, and this included such things as coordinating the staff to take the physical and biomedical measurements, as well as creating databases, data analysis, writing the reports for stakeholders, as well as academic publications. So this stuff is now my bread and butter. I've lectured in statistics and epidemiological methods. I'm currently leading the quantitative component of the Aged Care Victorian Visitors Scheme evaluation, and this is through a government tender with my colleague, Dr. Barbara Barroso-Nerves, who's leading the qualitative evaluation component. So talking from communities, I tend to find that getting ethics is an issue, so that then that's where I can also help community groups. If you are interested in evaluating, it's really easy for me to do that through our ethic review boards. So I love thinking about what data to capture, reducing participant fatigue, which is really important, creating protocols, obtaining ethics, creating online surveys for participants to complete, creating databases, undertaking data analysis. This stuff is easy for me. I know it's crazy, but I love it. It's like my joy. So please contact me if you think I'm helpful. So today I want to start by saying how much evidence is enough. And I want to take a learning from tobacco and lung cancer. There's quite a few different papers on this topic. Tobacco and lung cancer is like the epidemiologist's dream because no level of tobacco is good for you, now that we know that. And so there's a clear causal effect that we've created using epidemiological evidence. What I'm showing you here, I'm going to step away from the lectern, is for the people that can't, that are not familiar with sort of how to interpret this, is each line here is a different study assessing ever tobacco and lung cancer that was conducted in North America. So the study started in 1938. This is the line that indicates whether or not a study is statistically significant. So if these little lines, these are 95% confidence intervals, are hitting this, it means it's not statistically significant. But because if they're all on one side, this means that there's a detrimental effect. And if the evidence was on this side, it would mean that it was a positive effect. So this side here would be that smoking tobacco would be good for lung cancer. This side means it's bad. So my question here for the audience, for you to think about, is if you look at all of the studies from 1938, it goes down at the moment to 1971. At what point do we think we had enough evidence to show that ever smoking tobacco, whether you've quit or not, is bad for you for lung cancer? Out of curiosity, anyone want to yell out a number? I'm not sure if you can read it. It goes, so 1938, 1955, 1960, 1965, 1970. Anyone brave enough to yell it out? Where they think? 1965. So I've put some 2 lines up there. So that's 1960. Maybe needed a little bit more evidence. 1970. I think that we had enough evidence, right? The problem is that people continue studying this. So this is all the evidence from 1938 to 1993. What a waste of time and money, right? And this isn't just in North America. The same thing was happening in Europe. They're no different, and in Asia and everywhere else. So from my PhD student, Danny's done a great job. He was synthesising the evidence as part of a systematic review. And what they found was that there are several systematic reviews that have identified the benefits of an improvement from social prescribing to self-reported health, well-being, quality of life, self-esteem, mental health, anxiety and depression, as well as the social health constructs of strengthening social contacts and minimising socialisation. Not as much evidence around loneliness. So, controversially, maybe we could just stop assessing these measures and focus on other measures. Now, if I say that to you and you're in a community group running your own socially prescribed program, you may say to me, but I don't have the evidence for my program. And what's really great about these systematic reviews is that they're heterogeneous with the type of programs that they're evaluating. So that means that they are different in how they function and what programs are being offered. So you probably, if you go to these systematic reviews, you may find elements that are very close to yours that you can draw on their evidence. It means that the evidence is a bit more generalisable as well, so just more broadly. Okay, so there is a caveat. So how much of this international research is generalisable to the Australian, our native land? I would say that regionality is an issue with where our understanding is, and just generally around our social health, like proportion of people that are lonely or socially isolated versus metropolitan. I get asked that all the time from the media, and there's evidence both ways. I can't say a comment around that. Our very specific COLD, so cultural and linguistic diverse communities specific to Australia, as well as ill health subgroups that are interacting with our very specific healthcare and social support systems. These do vary by country, so we just have to be a bit careful. So then moving on from those aspects that I believe has enough evidence, I think that through our Delphi we're indicating that quality of life is probably still a great measure as a blanket. If everyone had one measure of those, let's go with quality of life. So what about these other measures? And this is where I think it's really interesting that people say, I've been hearing that the funders say that there's not enough evidence. Now, my question for you to ask these people is, what evidence do they want? Because I doubt that the Department of Health or NHMRC are going to be persuaded with more evidence on wellbeing and quality of life. I think that they're probably more interested in health measures, benefits to lifestyle risk factors for chronic diseases such as physical activity, benefits to blood pressure. Like if we could show that our social prescribing benefited blood pressure to even 5 millimeters of mercury, I think we would have a lot of medical people on board with social prescribing. And then, of course, return on investment and health care utilisation. I think that these are all measures that we've been talking about during this conference. And there's no reason why we can't show this. I think my research demonstrating our link between social health and chronic diseases, as well as my broader work around social determinants of health, shows that the evidence should be obtainable for these measures. I want to highlight a systematic review that I undertook looking at social prescription and physical health. We took a very, very strict, now I realise, definition of social prescribing, and it was the healthcare model through a GP with a link worker. We assessed a lot of papers and only 8 were eligible. We did find a benefit to physical activity, and for those that would like to see the evidence that are academics in the audience, we found that there was a benefit straight after completion of the program. So the programs usually went 2.5 months to 6 months in length for social prescription, and then also assessed after the intervention stopped. And I think that's really an important point, is that I would really like to see some long-term evidence around social prescribing once the initial support system has been removed, whether or not they continue going to social prescribing groups without the link worker involvement and follow-up. And here we're assessing it up to 12 months, which is a really nice timeline as well for healthcare utilisation. I would say that if we're going to include that, we need at least 12 months. In these 8 studies, I didn't see anything around adiposity, blood pressure, and the caveat here is that we've just heard from Thomas's talk that he did find positive or improvements in blood pressure from nature prescribing. Again, we have slightly different eligibility for our systematic reviews. No benefits in cholesterol or glucose, and there were no eligible studies that were targeting unhealthy diet, smoking, or other lifestyle behaviours that we're interested in. There's 2 cautions here. We were very much restricted to the academic literature, and this is actually one of the points I wanted to make, is it's really important to try to get any reports around your evaluations into academic literature, because it's so hard for us to search grey literature around anything when we're doing systematic reviews. And systematic reviews are so difficult in the first place that it's sort of one of the first things that will get removed from the product. Like even if we intend to search grey literature, we might not do it. So again, getting that ethics ahead in before you start your evaluation is important, but there is retrospective ethics as well that's available if you've already collected data. And the other point is that these were all socially prescribed group physical activity, and mainly from the UK. There's 8 people. So that no wonder we saw a benefit in physical activity, right, from these 8 programs. And And this brings me to a point. So I was looking at why we had 8 physical activity group-based socially prescribed activities that were only eligible. That's all I could find in this very restrictive model. And I found that in the UK, before social prescribing, they had a system where GPs could prescribe physical group activities, like a subsidised version, and it was already in place. So the social prescribing has sort of been able to piggyback off that system in a way, like it was a structure that GPs were already, comfortable with, I guess. And I've been trying to think about ways we could piggyback off systems that we already have. And Dr. James Ibrahim mentioned that the way that they're thinking about doing it is through the mental health plan in his practice. And because I work in chronic disease, I also know that there's a heart health check with the Medicare code, and a lot of the risk factors we're discussing that essentially they're trying to encourage people to do are physical activity and healthy eating, and these can be socially prescribed. So I think there are opportunities, and these are just 2. I'm sure there's more opportunities, and if we just understood how we can integrate it into our current system, I think we could get there faster. So what I'm advocating for is that when we evaluate, we could just do the easy ones. These are easy. Lifestyle risk factors through a survey, physical health measures of blood pressure, weight and height. These are objective, non-invasive, can be done with surveys and machines. Could assist with economic benefits. Could be seen regardless of whether we see benefits to social health, quality of life and mental health. Wouldn't it be great it would be great to see benefits on all measures, but maybe, if we don't see it in loneliness, but we do see it in blood pressure, that's still a positive. So I think just broadening the amount of measures give social prescribing a good chance to get evidence. And then in healthcare utilisation and economic benefits, at a system levels, there are some studies that have shown reduced healthcare utilisation and cost effectiveness. I found a few there, it's referenced in that paper. There are opportunities though for linked data, which came up this morning in the breakfast session, for PBS, MBS and MADIP, that we could be trying to improve. We do need money for this linkage, and we may need longer follow-ups. But this doesn't necessarily mean longer follow-up with the participant. So we could ask participants whether it's okay to link the data at the beginning, that's what we do, and then they do the program and we follow them up for a year, and then we go to link the data after 2 years. So it doesn't affect us having to follow up the participants necessarily with individual one-on-one. So point number 1 was really long. The other points that I want to make today are much shorter. Number 2 is about optimising social prescription. So when I talk about social prescribing, I really think it's of benefit for policy that we don't compare social prescribing programs generally at this stage in the evidence, but later on we can assess whether or not there's benefits with different programs and different aspects. So one of the things I've been thinking about is referral type, the presence of a link worker versus not, and then how the link worker functions, like the number of visits. The literature that I've read says that it can be up to, I think it's 6 on average, but some people are only having 2 and other people are having 16. So does that make a difference? And of course, online versus in person, I think that needs some attention at some point. I think that we probably will find that in person is better, but probably need some evidence around that. I also want to ask if there's a step missing around behavioural change strategies generally, and how much of this is actually being done already by the link workers, and if it could be just standardised, like we could share that information and everyone sort of does the same thing. Those resources could be shared, that what we're finding easy. Okay, final point is around randomised controlled trials and pros and cons, potentially getting away from them. This is, I know that there's only a select audience that would be interested in continuing this, but I just want to be clear that a randomised controlled trial is like the gold standard for biomedical treatments. So this is where the assumption is around how our body physiology is essentially the same, and when we put a drug in it, that it should effectively be similar across, with some, obviously age and gender may differ, but we are very similar with how our body physiology works. Now, when you get to lifestyle interventions, people are very complicated, complex human beings with all different things going on, motivation, and also opportunities. I think that randomized controlled trials doesn't necessarily take into account these differences. And I've just going to say that if you really want to do a randomized controlled trial, I've got a paper that looks at different designs that you might want to do, like a tutorial. If you're going to do it, the question is, how can you ethically not offer social prescribing to someone that you think would benefit from it? So who's going to be in the control group? This is where a step wedge design or wait list control, same thing, different names, becomes preferable. So what happens is that everyone enters your trial, you put half the people into instant social prescribing and the other people have to wait for a certain time before they get their social prescribing. And you're measuring them at baseline and then again before the second cohort gets social prescribing and then follow up. But then ethically, how long can you delay treatment of social prescribing? Can you really make them wait 3 months until a link worker contacts them? I just think that there's a few questions there we need to think about if you're really, really eager to do a randomized control trial. So if you're not going to do a randomized control trial, the difficulty then is obtaining a comparable reference group. And there are so many reasons, I'm not going to go into it, but probably the reference group is going to be healthier. And then you're probably, if you're going to compare to a healthier cohort, you might not see the benefits you want from social prescribing. So then we're sort of left with this before, after in the same individual, which is actually my preference. I think that, talking about complicated humans, and I just think before and after, and there's different statistical approaches, like a difference in difference analysis that sort of helps with, it's quite a progress area. So yeah, I'm going to leave you there with that. The last methodological thing is, this is more general, is who is social prescribing for? I see a lot of studies that are excluding, or it's only for those who are socially isolated and lonely. I feel like maybe we could remove this now and say, let's just include everyone. And then when we do the analysis, you can look at the high-risk groups and say, in the high-risk groups, how much did it benefit them for blood pressure or loneliness? You don't need to exclude people anymore, I think. And then who's being excluded is around the basic needs of not being met. Now, for evaluation, maybe we need to continue excluding these, but then I saw some of the work that JR's been doing with his PCCS program, and there are people accessing his community supports that don't necessarily have shelter. So maybe there is, I'm sort of feeling there might be some wiggle room there. I'm not 100% sold on that. But if they, for instance, if they've got chronic mental illness and that's going to prevent them from being, going to the social prescription groups, we just need to think about that. A big summary with all the things that I've been talking about, but I think more broadly, what I want to say is that from listening to the people from the UK and Canada, I see their frameworks with how they've put together where social prescribing fits within the healthcare system, and they keep referring to social determinants of health. And I don't feel like we have that strong bond here, and I feel like we need a bit more of a framework. And also just it's because generally our work in social determinants of health is well behind. We're a bit lagging in making that an important aspect of health. And I also just want to make sure that I acknowledge Kay. I can see you up the back. Could you give everyone a wave? Kay from ADMA. Hi. So Kay has been invaluable support for me through this. She has a wealth of knowledge around barriers and enablers. She's been supporting us in Victoria to connect, and it's how I met JR in the first place, so I wouldn't be here. And thank you for all your time explaining when I've been putting in for funding around this. I think it's just such an invaluable resource having people around you that are willing to support your research. Thank you.